like them for review at any point. All right, can everyone see here?
Yes.
Right. So I'm Sean Johnston, and this is my colleague Emily, and we are both naloxone coordinators with Southside Harm Reduction. And so this is a Narcan training. We'll start with the basics, like what is Narcan? You may have heard the terms Narcan and naloxone, and they're the same thing. Narcan is the brand name, like Kleenex is to tissues. And so we'll probably use the terms interchangeably just as we're talking. So we're just talking about the same thing. And naloxone is an opioid overdose reversal drug and an opioid antagonist. And that means that it's going to bind to the opioid receptors in your brain, but it's not going to activate the downstream effects. It's not going to send the signals the same way that an opioid would if it binds to those receptors. So it blocks the effects of the opioid in effect. Naloxone is safe. That's the best part, and why the law allows us to distribute it so easily is that it's not going to harm someone if they're not overdosing on opioids. A lot of problems that aren't an overdose might look like an overdose, but just know that you're not going to make the situation worse by administering naloxone. If you have any reason to suspect that opioids could be involved, you should go ahead and administer naloxone. But also important to note that naloxone is temperature and light sensitive. So when Southside gives out naloxone kits, we send them out in amber baggies that are going to try to protect it from light degradation. And then the ideal temperature is around room temperature, but mainly we just want to discourage people from letting it freeze or like leaving it in a hot car. So don't leave it anywhere you wouldn't leave your dog or your child. The forms of naloxone. In the center, we have the mythical Evzio. They're crazy expensive, upwards of like $1,000, $1,500 each. I've only ever seen a trainer at the clinic that we work with. You pull off that top part and it actually talks and guides you through the process. So we won't really do much training in terms of those, because if you have one, it'll take care of that for you. On the right is the next most expensive. That's the nasal naloxone. And that's fairly affordable, but in terms of, in comparison to the intramuscular vials that you'll see here on the left, it's around like 20 to 50 times more expensive. So in the interest of getting as much out to the public as possible, Southside focuses all of our finances on intramuscular naloxone. But if you aren't comfortable with needles and you would like to get yourself some nasal naloxone, you can do so at like your local pharmacy. Don't think you need a prescription. Minnesota has good third-party prescription laws. But on the left, that's what we'll be focusing on today, because that's probably the method that requires the most knowledge to use. So how does it work? We talked about it briefly with the receptors. You got our cute little simplification cartoons on the left there. You've got your opioid receptor that the opioid binds to. And we like to say that the naloxone knocks off the opioid receptors. And that works by being it binds to your opioid receptors better than the opioids. So it outcompetes it. However, naloxone has a shorter duration than opioids. So that's something to keep in mind that we will touch on later in the presentation. It has the unfortunate side effect in someone that has used opioids of causing immediate opioid withdrawal, which can be extremely not fun. Do you want to take it from here, Emily?
So what is an opioid? Opioids are chemicals that interact with the opioid receptors in your brain. They reduce the intensity of pain and produce euphoria, all those kinds of things. When prescribed by a doctor, they can still be addictive and the body can still develop physical dependence. Common opioids that you will have heard of are going to be heroin, morphine, fentanyl, methadone, oxycodone, Percocets. They're all kind of listed there in the bottom. And then just a note, you may hear the term opioid and opiate somewhat interchangeably. They do actually have different meanings. Opiates are organics, whereas opioids encompasses both organic opiates and also synthetics. What is an overdose? So opioids are depressants, and in an overdose, you'll see decreased function of central nervous system and the respiratory system. The body is then unable to breathe normally. The heart's not pumping properly. Oxygen is not circulating, and there can be brain and soft tissue damage from lack of oxygen. What does it look like? It's going to be loss of consciousness. Breathing might be slow, erratic, or completely stopped. Clammy and cold skin. Fingertips and lips might turn colors for somebody with lighter skin. That's going to be blue and purple. For people with darker skin, that's going to be gray. You might see vomiting. You might hear gurgling or kind of snoring sounds, extremely constricted pinpoint pupils. The person might appear to be awake but not able to speak. The person would be unresponsive to stimuli. There may be dizziness or confusion, or the body might be very, very limp or very, very stiff. Something that's important to know is if somebody is at all responsive, they are not experiencing an overdose at that time, and you should not give them naloxone. Calling for emergency medical services. So you're going to want to keep legal considerations in mind when you're determining whether or not you're going to call EMS. If there's someone on the scene who knows the person who is overdosing, you might consult them to see if they would know if the person would consent to calling EMS. Either way, though, if you are unable to revive the person using naloxone, you're going to need to call EMS. List of legal you're not going to mention overdose. Instead, you will say that the person is unresponsive or not breathing. When EMS do arrive, you'll tell them how much naloxone you've administered. And if police arrive, you're going to want to do your best to answer questions kind of as vaguely as possible and without offering any incriminating information. And your role then would be keep the police talking to you so that EMS can do their work with you.
You're a little frozen there, Emily. Is that just me, or is everybody else seeing that too? Okay.
It's the same for me, yeah.
Okay, she usually comes back in a few seconds.
Can you all hear me?
Yes, there we go.
Okay, I'm sorry, where did I lose you?
This whole slide, I think.
Oh, the entire last slide or this slide? Rescue breathing? Mm-hmm. Okay, great. I hadn't started that one. Great. So rescue breathing and considerations to make. So mouth barriers, which will be provided in your Narcan kits, may not protect against COVID-19. So for that reason, if there's a person on the scene who already knows the person and may be potted with them, you might see if that person is willing to perform rescue breathing just to kind of minimize exposure. Before you do rescue breaths, you're going to want to move the person onto their back if possible and tilt the head, as you can see in a little graphic, to clear the airway, to open the airway. Rescue breathing steps. So as discussed, you're going to move the person onto their back if you can. Give a visual check to see if if the airway is blocked, by opening the mouth, and tilt the head back while lifting the chin. If you have a mouth barrier, you're going to place it over the face. You're going to pinch the person's nose and breathe into their mouth for 1 second. If you can't get the mouth open, you can still breathe into the nose instead. And in that case, you will not be pinching the nose shut. You're going to want to watch for the chest to rise, and give breaths about every 5 to 6 seconds. Take it away, Sean.
Always have trouble unmuting in the screen share mode. So this is kind of the meat of the presentation. So to prepare the intramuscular naloxone, your kit is going to contain anywhere from 2 to 4 of these vials, and they're going to have that little orange cap on the top like you see in that first picture. Those caps don't really go back on, so not something you want to just like mess around with. That's for when you're ready to use it. And then you're going to remove your syringe. The syringe usually comes in a little blister package, so plastic wrap. So you just open that up, and then the tip of the syringe will be placed on top of the barrel, but it's not usually twisted all the way on in the package. So you want to just make sure you give it a quick little twist. Otherwise, when you go to push the plunger, you can shoot the needle off, and that's not fun for anyone. So yeah, make sure that's secure. And then that's also going to have a cap over the needle. So you're going to want to remove that carefully. And then you can see in this picture with the blue gloves, you're going to want to invert the vial. And it can help to sort of hold the vial with 2 fingers while holding your syringe with like your pinky or your ring finger. So just all of that being done with one hand, and that leaves your other hand completely free to be pulling back the plunger. And you're gonna wanna make sure that your syringe tip is below the liquid line. And I'm looking in the chat about not shooting the needle out. Okay, so in the package, the syringe and needle are gonna look like they're connected, but it's called a lure lock connection, and they're not one piece, they're actually separate pieces. And so in the package, they're kind of placed together, but they're not all the way twisted together. So you just wanna give it a quick little righty-tighty twist to make sure that your syringe is all the way connected. Yep. But yeah, so you're inserting the syringe into that little rubber port. You can see in that second picture, after you've taken the orange cap off, you have a little dark gray rubber membrane, and that's where you're inserting the syringe. If you're feeling confident, it can help to pull back a little bit of air into the syringe, just because the plunger can be a little sticky when it's first fresh out of the package. So pulling a little air in both helps to free up the plunger. And then you can press that air into the vial, and that's going to break the vacuum that exists in the naloxone vial and just make drawing up the naloxone that much easier. But if that's too complicated, it's an urgent situation, don't worry about that. Just work on getting the liquid into the syringe. So keeping the syringe below the liquid line, draw up as much liquid as you can. No need to spend minutes, precious time tracing every last drop. Just get as much as you can. The syringes are going to be 3 milliliters, and then each vial only contains 1 milliliter of liquid. So that's just something to keep in mind. So that if you're freaking out that there's only a third of the syringe full, like that means you did it right. A quick flick of the syringe with the needle pointed up in the air can help free the bubbles, and you can just give that a quick squirt out. But oxygen in an intramuscular injection is not a huge deal. It's not like Hollywood would have you believe where an air bubble is going to kill you. You're just going to maybe have a little bit of a sore muscle afterwards. So that's not something to worry about too much either. Administration. The injection sites ideally are going to be the shoulder, just like a flu shot or a COVID vaccine. Secondly, we would recommend maybe the thigh, just meaty, muscly areas, or then or the buttocks as a last case scenario, just because that can be where a lot of nerves are, it can be painful. But if you are going for the buttocks, picture a cross on the butt cheek, and you want to go for the upper outer quadrant. And that's where you're going to want to aim. In winter, if someone's wearing a heavy coat, maybe you're going to want to go for the thigh or the butt, but the needle can go through fabric like jeans. It's just fine. You don't need to undress the person, but maybe just something big like a parka would be better to just avoid and go for the leg. And for the injection, you're just going to do a swift dart-like jab, roughly 90-degree angle to the skin, and just try to have the needle in there all the way. You don't need to jam it in there, but it's better than having it like part way out, and it can really help stabilize the syringe. It's just all the way in, and then using your thumb just depress the plunger all the way. Yeah, no need to worry about going too fast or anything. Just depress the plunger. Carefully pull the needle out, and then we recommend not recapping the syringe because you've just injected a person and you don't necessarily know their blood work. So we don't want you to accidentally stick yourself in the attempt to recap. So just put it away from anyone. A sharps container is ideal, but if you don't have one, just keep it away. And then as far as administering nasal naloxone, that's a lot more straightforward. It's just going to come in a little blister pack. You're just going to take it out. It might have a cap on it. You're going to hold it just like in that picture with your 2 fingers on the little shelf there, and then your thumb on the plunger. You're going to insert it into the person's nose until your fingers are touching their nostrils. No need to jam it up there. Yeah, and just depress your thumb all the way. And then if you do need additional doses, you just alternate nostrils. And with both intramuscular and nasal, you're going to want to wait 2 minutes at least between doses. And this is because you don't want to over-administer, because this can make, how many doses is in the nasal? It is a single, you would do it all at once. So I don't know the equivalent. There's about 4 milligrams of naloxone in the nasal and only 0.4 in the intramuscular, but that doesn't necessarily mean that there's 10 times more naloxone because of bioavailability. You get a lot more of the naloxone into the system when you're injecting it versus in the nose. You need more to achieve the same effect. But yeah, waiting 2 minutes between doses is important to avoid extra more withdrawal symptoms than are necessary. And while you're waiting, that's a good time to administer more rescue breaths, and then putting the person in a recovery position if you're not going to be able to be right there. So we don't want the person to aspirate on their own vomit. Repeat these steps until either the person revives, you run out of naloxone, or EMS arrives. Those are like the 3 endpoints that are possible. If EMS arrive, tell them how much naloxone you've administered. So the naloxone worked. I think I'm just stepping into Emily's territory. Emily, you want to speak over?
Sure. So what to do after the naloxone work? So you're going to want to be prepared for a variety of reactions from the person who was experiencing the overdose. And you're going to want to stay with them for as long as you can, or as long as they're going to allow you to stay with them. You might suggest that they don't use for another 90 minutes. This is because, as Sean mentioned earlier, the naloxone has a shorter lifespan, so it is possible that the naloxone can wear off and we could have another overdoses on our hands or their hands. If the person walks away, if you have any Narcan left, send it with them. And then go ahead and give us a call or shoot us an email, or any other SSPs, that's syringe service programs, to get more naloxone. Some legal considerations. So we have what's known as Steve's Law here in Minnesota. It's also known as the Good Samaritan Law, and it provides some limited protections to people who call 911 and or administer naloxone in response to suspected or known overdose. So some of those limitations, the law only provides immunity for the person overdosing and the person administering the naloxone. It does not cover anyone else in the area, at the scene. So if there are other folks around, it is a good idea to say, get out of here before emergency services show up. The immunity only applies to charges for the drug and possession directly related to the overdose. So not, correct me if I'm wrong, Sean, but I think a good example is if the person's overdosing on opioids and has methamphetamine on them, they can still be charged for possession of the methamphetamine, just not the opioid. Immunity does not apply to any ongoing investigations for prior charges, other crimes at the scene, purchasing or selling drugs, or any active warrants. That feels fairly self-explanatory. If there's anything else going on that is not related directly to the overdose, that person could still feasibly be arrested. Information obtained at the scene can be used in any ongoing Child Protective Services cases. And then, just so that you know, naloxone is legal to carry, and it is legal for any person acting in good faith to administer to a person that they suspect to be experiencing an opioid overdose. What was that question that I just saw in the chat?
Asked, in what situation would supporters or bystanders be legally targeted?
So you would not be charged, to my understanding or knowledge, unless you had any active warrants, or if you were also in possession of illicit substances. Like medics often travel in other groups. Yeah. So unless you're doing something that is illegal, if you're just responding to the overdose, you're not going to be detained, arrested, anything like that. It would have to be something else going on.
I believe our commentary, as far as like having other people clear the scene, is more directed for like encampment work. If you have other people in the area, friends of the person that might be holding at the time, you just don't want to get them in trouble, so we have them scram. But yes, if you're not, have nothing to worry about, then you can stay put.
Yeah.
Are you done with this slide?
I sure am. More questions? Sean, do you want to maybe turn off screen sharing so that we can see the folks we're talking with?
Sure thing.
Awesome. Does anybody have any other questions?
I have a question.
Yeah.
Oh, okay. I think you covered this, and I just wanted to go over it again. So responding to an overdose, you would call emergency services no matter what, or would that depend?
So it's kind of a tough one. Given that there are legal considerations, so that some folks are not going to want emergency services called for them, you may not call 911. And also, it is possible that the Narcan would not work, depending on the potency of the substance, or if there are other substances on board, like benzodiazepines or another, maybe I'm trying to think of something else, but we'll just go with benzodiazepines. Naloxone does not work on benzodiazepines. So if the person is experiencing overdose of multiple substances, naloxone's not going to help you, and you're still going to need emergency medical services. So the consideration to make is, if you can get consent from somebody who knows the person, and says, you know, I believe that they would want you to call EMS, that's great. But being time sensitive, you may want to consider calling EMS as you begin to administer rescue services, naloxone and rescue breathing. Or if you've administered a couple doses and you're not getting a response, you may then choose to call EMS. If your naloxone has not been effective, at that time, no considerations to make. You're just going to call 911. As that, I know that's not a super clear answer, but okay.
And then in the chat, I think you sort of covered this in your answer, Emily. People were asking what other types of overdoses show similar signs to an opioid overdose, and how to determine what drug is being used. So like Emily mentioned, benzos are going to look very similar potentially, but it is not your job necessarily to determine which drug is being used. If it's possible that an opioid has been used, like we said at the beginning, naloxone is not going to make the situation worse. So it could possibly be that the person is experiencing a polydrug overdose, like benzos can make it easier to overdose on an opiate, then even just removing one factor can be very helpful. But yeah. And then does calling EMS automatically make the individual subject to legal repercussions? No, I don't believe so. Steve's law ideally protects those people. We only point out the weaknesses in Steve's law just to avoid giving people a false sense of security that, oh, everyone here is holding an 8-ball, we're going to call, and then suddenly you have 5 people getting charges. We just don't want that unexpected scenario, so we try to include those little caveats.
I had a question about kind of what David brought up, because I had heard, I don't remember where, about the possibility of calling like the local fire department and have like an ambulance come through them instead of 911. Have y'all heard of that strategy?
I think that I have heard that suggestion in the past, at times when I myself was using in various states. I don't know how one would do that and what the efficacy would be of that. So my suggestion, our suggestion, is that if and when you call 911, you specify that you're looking for EMS services and you do not mention the overdose. Mentioning the overdose could provoke police involvement.
Cool.
Does that answer your question?
Yeah. And I also went and grabbed my kit from like an earlier training to show, because I think Kristen was asking questions about the needle being like connected. I don't know if you can see that, Kristen, but that's the part I think they're talking about, making sure it's tight, right? Yeah.
Yep. So where
cool.
the loop it connects, that's where you're going to want to give it a little twisty to lock it in. And also, if anybody here does not already have Narcan, needs to come get Narcan, you're welcome to come here to the office Monday through Thursday, 2 to 6 p.m. And anybody who's working here will be able to answer any questions if you need like kind of more visual aid or anything like that, or more of a hands-on.
Just on like getting Narcan, we were planning on putting out like a Google form. So if any of you need Narcan, I can go and pick it up and then redistribute it to folks who are on campus through that, just to make it a little bit easier for everyone. So we'll put that in the chat at the end. But yeah, thank you so much. Go ahead.
Nothing. I wasn't saying anything.
Okay. I think there are a couple more questions in the chat. I know it's kind of hard to see the chat when you're on the phone, so I can help read them out too, if that's helpful.
Thank you. Yeah.
Let's see. I think Kristen is asking, where did it go? How often does it happen where someone is given naloxone, but it doesn't help because it was another drug?
That's a good question. I don't, so for myself personally, in my own experience, all of the overdoses that I have responded to, I did not have Narcan at the time. And this was years ago when it was kind of more common for police to be confiscating Narcan. Which is to say, I mean, I don't have any like direct experience of administering naloxone and having it not work. What we are hearing though is that there are reports of benzodiazepine in some areas. I don't think I've heard of it necessarily here in Minnesota, but if it's happening anywhere, you can kind of be sure that it's gonna eventually find its way. So benzodiazepine being cut into something that's being sold as heroin, which then of course has the effect of compounding the response, what is the word I'm looking for? Sorry. The effects of the drug that's being used. So what we get reports from participants fairly regularly that they're having to administer upwards of 4 doses. Sometimes what I've personally heard as kind of the highest limit is 7 doses. And that is probably due to people using substances that have been cut with fentanyl or potentially another substance. So as far as how often, I don't have like a good hard number to give you, but it is something that happens and happens with some regularity.
I think also I've seen on the Southside harm reduction Instagram post, you've reposted things that let people know like if there's been reports of other things being cut into the drugs, which I think is really helpful just to like keep your knowledge of what's going on in the area up to date.
Yes. Thank you. We agree.
Yeah, it's very helpful, I think. Christian's also asking, are there other colloquial names we should be aware of that refer to opioids?
You know what I heard, actually, this was funny. I hadn't heard this in about 10 years. Sometimes opioids are referred to as boy, whereas cocaine is referred to as girl, which is an interesting one. A lot of folks will just say up or down, obviously referencing the effects of the drug. Fetty is something that you'll hear a lot. That specifically references fentanyl. And some folks are like specifically seeking out fentanyl to use. So there's a distinction there, but it is still an opioid. Sean, can you think of anything else?
Well, less common, just like H for horse.
Yeah. Yeah.
Yeah.
That's really helpful.
Yeah.
Thank you. And then another question from Amanda is, if naloxone is stored in the cold in our cars during the winter, how much does it hurt the shelf life?
Like that question. Not very much. We have seen studies that are done independently, like not from the pharmaceutical company, where they've had naloxone that is both expired and going through freeze-thaw cycles. And so that's like the most harmful thing that the naloxone can experience. And it was still 97% effective. So I think that's just something they put to cover their butts, maybe pad their profit margins. Who knows? That's a conspiracy theory. I don't want to get in trouble for spreading that.
Would you say that also applies? Sorry, David. I just want to get my question in quick. Does that also apply for like expired Narcan? Like, do you see it still being as effective?
Yes. So we would definitely recommend not throwing away naloxone. I think our current batch expires in like March of 22. But yeah, ignore that. If you can get new stuff, go ahead and get some new stuff. We'll replace it for you. And a lot of other SSPs will as well. But if you don't have a replacement, go ahead and keep it until you can replace it.
Great. Okay, go ahead, David.
I just wanted to ask about the immediate withdrawal after administering Narcan. And so what kinds of things would people experience? And then I imagine it would be distressing. So what are some ways of is there any place to direct them or to like a resource while they're experiencing that?
I'll take this one. I think I might have more experience with opioid withdrawal, but that could also just be speculation. So opioid withdrawal essentially is flu-like symptoms with also restless legs. The skin becomes sensitive in a way that's just really awful. And runny nose, vomiting, diarrhea, all of those kinds of things. So, and unfortunately, with opioid withdrawal, if there are, of course, medications that if somebody's detoxing or something will be suggested, you know, acetaminophen or ibuprofen for aches. You can, you know, give somebody a blanket, but bottom line with opioid withdrawal is the only thing that's really going to soothe that is opioid. So as far as responding to a person who is experiencing, is it called precipitated withdrawal? I think that might be a buprenorphine thing. So if somebody's experiencing withdrawal symptoms due to having received Narcan, they might be very angry. I think the best thing to do is let them lead the dynamic. They may just want to get the hell away from you and go fix again. And of course, as we said, you might want to discourage people from doing that, but people are going to make their choices. And so I think really the best response is, you know, to maybe just say, I'm really glad you're alive. I'm sorry that you're feeling shitty. Can I do anything? And, you know, they'll probably say no and go elsewhere to get their needs met. But just knowing that like this person is having a really a traumatic experience of having overdosed, and then now also their body feels horrible and probably their emotional state is really compromised. So just like holding that knowledge and interacting with that person based on like this person is now suffering would be my advice.
And
I have a question too.
yeah, go for it.
Oh, did I just cut someone off? Okay.
Nope, go ahead.
Okay. If you don't have Narcan on you, what do you think you should do when you see a person overdosing? Do you somehow try to find some Narcan from somewhere, or do you at that point call 911? What would you do?
So I have successfully used rescue breathing to reverse 12 overdoses, and only rescue breathing, no other intervention. So it can be done. Those were situations that were like really extreme duress. I was using, other people were using. We did not feel safe or comfortable calling emergency responders, and we did not have Narcan. I would say if you don't have Narcan, if you know somebody, your roommate or your neighbor or somebody does carry Narcan, you might try to get that. But I would call 911. Would be my suggestion. You can pull it off without the Narcan, but there are no guarantees. And better. I feel for myself, I would feel tremendous regret if I didn't call in as much help as I needed in a situation like that, and then that resulted in lost life.
I asked a question in the chat about, besides being Narcan trained, how else to support community members who are drug users, and what other kind of like trainings or support, I don't know, that there could be done.
Yeah. This is maybe a convenient segue. We're running low on time now, but maybe a convenient segue to kind of more general harm reduction principles. Sean, let me know if I'm talking too much. So I think the best way to support people who use drugs is to try to break down the stigmas that we're all sort of socialized within ourselves about drug use. There's some, you know, a lot of the narrative that we're told about drug use and people who use drugs is that, you know, it's like one hit and you're addicted, and you know, people become these, you know, horrible monsters, they're thieves and they'll lie, and you know, completely out of control and all of that kind of stuff. And actually, you know, there's data that suggests that that's really not the case. So I think, to kind of turn a little bit, to pivot, so harm reduction to me is really, you know, there's the kind of practical foundation that is that people are going to make decisions and engage in behaviors that are potentially harmful. And so what harm reduction practically seeks to do is to mitigate those harms. So like seatbelts are an example that people like to give of harm reduction. Driving is inherently dangerous. You wear your seatbelt, it becomes less dangerous. But then also, I think from a kind of a more interpersonal and I don't know, philosophical, I guess, standpoint, I think the foundation is what's known as unconditional positive regard. I forget there's a therapist who coined that term. I forget his name, but so that essentially means that you're engaging with everyone, whether they use drugs or don't use drugs or whatever they're doing, you're engaging with them based on just acknowledging their inherent dignity as a human being, as a person, and regarding them with compassion, and with an understanding that, you know, no matter what they're doing, they are still inherently worthy of care and medical help and housing and all of the things that every human being is entitled to. So I think growing our understanding of those concepts, and then growing our practice, how we apply that knowledge, that understanding in our day-to-day interaction with people who use drugs, is one really important way of supporting people who use drugs. And then there's also like more practical stuff, like if you have friends that use drugs, and really any drugs, you can say, you know, hey, if you are in a place where you might be using alone, why don't you give me a call so that I can make sure that you don't overdose? Or, you know, if somebody is expressing ambivalence or maybe like considering making changes to their substance use, you might like be supportive and try not to be directive with that person, and really let them make their own decisions about their drug use. Knowing where people can get safe use materials, like syringes or smoking equipment, so other syringe exchange services, is really good information to have if you have a friend or know somebody who needs clean syringes. You can be like, here's this place that I know you can go to. Here's the phone number. So there's practical ways, but I think the bigger thing is really, you know, there's all these practical ways to support folks, and maybe these things come up in your day-to-day life and maybe they don't. But what does come up is the way that you choose to engage with people, strangers, people you know, whatever. And so I think that's like really the big thing to kind of hold on to. Does that answer your question? Okay.
You're muted there, David.
Thanks. I was wondering, where's the office at in South Minneapolis? Yeah.
Yeah, there was actually one more slide on that PowerPoint presentation that I didn't get to. You can pull that up. There we go. So yeah, we're right by a lake in Bloomington, just 2 blocks off 31st and 16th. It's the Walker Community Church. And yeah, we have our office hours 2 to 6 p.m. Monday through Thursday. We have our own separate little doorbell that you can always ring, and hopefully one of us will come bounding out.
right, any other questions? I guess I'd also like to hear kind of what I don't know, support we can give organizers like you all. And kind of, I know there's like donation that we can put on our Instagram and Facebook too. I feel like a global kind of group of organizers, or how can we support the people who are doing the safe syringe program? I think that's what you called it. Yeah.
Well, recent, like, hopefully there will be like legislation that's coming along in the near future, fingers crossed, because we currently have a grant involving OPS, the overdose prevention sites. So I guess just getting those conversations going with community members so that when those things appear on the ballot, we already have like a strong community base of people that are willing to support these things. And OPS is also known as like safe consumption sites, SDS. They have so many different acronyms depending on what part of the world you're in, but that's really been like revolutionary change in drug policy in a lot of other countries, notably Canada. Vancouver's downtown east side has just been completely transformed because of Insight, I believe, is the clinic that operates an overdose prevention site. And it's pretty much just a place where people who use drugs can be, and they can use and have access to clean works, and have trained medical staff on there to intervene and prevent overdose prevention site. And this isn't ridiculously radical if you think about it. Like, alcohol bars are safe consumption sites. Like, people who work at bars are trained to handle someone that overdoses on alcohol. They cut you off. They're not that I'm advocating that for an opioid safe consumption site, but and then we have federal regulations on alcohol supply. Safe supply is another really big term to just keep your eyes peeled for in upcoming legislation, or if a politician mentions those things, then they're probably a keeper.
Okay, any last questions anyone has? Okay. So we put in a Google Forms link into the Zoom chat here. If you guys fill that out, then we can know who would want some of these Narcan kits, and we can get them distributed to you guys. But thank you so much, Emily and Sean. This was really informational, and I feel like I learned so much. And I don't know, I really appreciate you guys taking out the time. We all appreciate you guys taking out your time and doing this for us.
Our pleasure. Thank you so much for being interested and for reaching out. We're happy to do any time.
Yeah, thank you guys for having us.
Thanks, y'all. Have a wonderful evening. Enjoy this beautiful sunshine if you can.
You too.
Thank
Bye.
you.
Thanks, everyone.
Take care, y'all.